I will talk about the methodological issue in acupuncture research. The esteemed British Medical Journal recently published a comprehensive collection of acupuncture with compelling evidence from research papers published over the past decades. The graph in the middle showed the rising number of studies, over 10,000 to date, with 1,000 randomized clinical trials published annually. There are also over 2,400 reviews. The 130 identified clinical practice guidelines provide 433 recommendations supported by various medical fields, demonstrating acupuncture's strong evidence base. The BMJ authors conduct a systematic survey to explore factors impacting acupuncture treatment effect in past 5 years RCTs with a sample size of more than 100. They analyzed 584 and identified 1,304 effect estimates. 5 key factors influencing treatment effect were identified: penetrating acupuncture, single center studies, higher treatment frequency, and reported funding were associated with greater treatment effect. International acupuncture experts emphasized the need for clear rationale and research questions before starting a study. Quality of life measures should be included as outcome assessment, and longer-term follow-up, at least 6 months, is suggested for pragmatic trials. Involving patient partner, and organization in trial design is strongly encouraged. This is a typical type of RCT. To accurately assess acupuncture's effectiveness and address alternative explanation, we must incorporate control group, placebo, randomization, blinding, and sufficient sample size in the study design. These elements help isolate true treatment effect and minimize bias. Let's look into the control treatment issue in acupuncture research. Controls used in acupuncture trial encompass various methods such as conventional intervention, standard treatment or usual care, waiting list, sham acupuncture. To verify acupuncture's efficacy, sham acupuncture closely resembles the real one, but without physiological effects are used. Sham technique includes shallow needling and sham device needling as a Baksham, Streitberger, and Takagura needle. Figures in the research show palm acupuncture on the left and sham device needling as non-penetrating control on the right. In 2015, Dr. Zhang from RMIT in Melbourne conducted an analysis of acupuncture trial involving sham device. Out of 36 included trials involving sham device. Out of the 36 included trials, their finding reveals the only 13 study demonstrated a significant effect of barrel acupuncture compared to sham acupuncture. Professor Che review paper highlights the complexity of placebo acupuncture in the acupuncture study. Placebo needles not only cue treatment expectation, but also stimulate the somatosensory system, making it challenging to distinguish specific effect. Acupuncture involves visual, verbal, and tactile context, influencing patient experience and outcomes. It is challenging to isolate specific effects in placebo-controlled acupuncture studies. The left slide shows how placebo needle in acupuncture trial blind participant, just like how pill in drug trial look and taste alike. Placebo needle in acupuncture look real but don't penetrate the skin. But there is additional factor, tactile context in acupuncture research. So some patients respond to placebo needles thinking they are getting real treatment. The RMIT group reviewed acupuncture placebo device and their blinding credibility after analyzing 15 trials. They found issue with the current sham device. They point out flaws in current placebo acupuncture device. The Stripburger and Baksham needle feel different at some sensitive point, affecting blinding. The Takakura device effectiveness is unclear due to few study, and real acupuncture might cause unblinding. Future design should address these issues. Let's talk about the barium acupuncture in clinical trial. It is crucial to focus on studying barium acupuncture, considering the heterogeneity in needling method. Barium acupuncture in different trials could yield varying effects due to these differences. First, barium acupuncture in trial without base unit might closely resemble real clinical practice. Second, however, barium acupuncture in trial with base unit, the effect of barium acupuncture could deviate from real clinical practice. For instance, figure present an example of barium acupuncture with base unit, where needles are only inserted into the double side, tape below the fringe, not skin. Such variation interrupt the regular needling practice in terms of depth, direction, and manual technique for touch. Using sham device to blind participants may limit assessing specific effect of acupuncture, potentially attenuating its true impact. Through network meta-analysis, we aim to identify any difference between barium acupuncture with base unit and without it in managing menopausal hot flush. We found 8 eligible studies for further analysis. However, we could not directly compare barium acupuncture with base unit against the barium acupuncture without base unit. Instead, we perform an indirect comparison using waitlist group as a common comparison. The network meta-analysis showed the barium acupuncture without base unit was significantly more effective than acupuncture with base unit. Shallow needling also had more beneficial effect on reducing menopausal hot flush compared to barium acupuncture with base unit. The figure highlights the substantial favorable effect of shallow needling of a sham acupuncture device. Our findings indicate that the barium acupuncture without base unit has larger effect size than barium acupuncture with base unit. This suggests that the presence of base unit in the barium acupuncture trial may compromise the treatment effectiveness compared to real acupuncture in real-world clinical setting. As the Professor Hang-Sung Lee said, in the context of paradox in acupuncture research paper, one interpretation is that effect of acupuncture not being superior to placebo could be attributed to the barium acupuncture with base unit not being equivalent to real acupuncture practice. This is my last slide. To improve the quality and incredibility of acupuncture research, we should focus on enhancing reporting quality through guidelines like accurate preclinical registration in clinical trial registry for transparency. So the third one is Prospero registration for systematic review to reduce bias, and using appropriate research design for robust result, involving patient in research priorities and guideline development, including real-world data for valuable real-world evidence. These steps will produce trustworthy evidence and enhancing the effectiveness of the acupuncture practice. Actually, there is a more slide for the network meta-analysis for sham using the sham device clinical trial. The Dr. Boramni will show the more results at next talk. Thank you very much.